Rishi, can we go live? We are ready. Rishi from OrthoTV. Hello.
Yes, sir. We shall go live. We are
Okay,
live now.
we are live now.
Yes, sir. We are live now.
Yeah, okay. Hi. Good evening, viewers. I'm Dr. Balamurali. I'd like to welcome you all to this ISSICON pre-conference series of talks based on spine trauma. I just wanted to introduce you to the ISSICON conference, which is the International Spine and Spinal Injuries Conference. And this year's theme is New Era of Spinal Cord Injury Care. So this is a meeting very focused on spine trauma and rehabilitation. So you have a combination of three societies: the Spinal Cord Society of India, the AO Spine Knowledge Forum for Trauma, and the Asian Spinal Cord Network, which is a very large meeting organized by Kauvery Hospital and Hamsa Rehab. So in this meeting, you will have a combination of various societies, including the Chennai Ortho Spine Society and the Chennai Neuro Association, who will be participating as well. It's happening between the 31st of October and 2nd of November at the Hyatt Regency in Chennai, which is a five-star hotel. So we welcome you all, those who are interested, for this huge extravaganza of academic program on spine trauma, to please register yourself. So we're expecting about 300 to 400 spine surgeons, about hospital representatives, and about 300 plus rehab specialists, which includes rehabilitation specialists, occupational therapists, speech therapists, nurses, speech, and various other researchers and technicians related to and working in the field of spinal cord injury from all over Asia and India in specific. All the stalwarts of the spine community are faculty and will be attending this meeting, both from Chennai and from all over the country. We have very special guests. We have Dr. Alex Vaccaro, who is a very renowned name in spine trauma, who's coming in person. And along with him, there's a huge fraternity of about nearly 30 international faculty who are coming from various parts of the world. We also have a workshop day, which will be on the third day, which is November 2nd. There's a spine boot camp, which is very specifically focused on various skills that you need to acquire related to trauma. So I once again welcome you all to the ISSICON conference. And as part of the conference, we wanted to introduce you and discuss about specific topics. These topics will all be dealt in detail during the conference. In the entire 3 days, we're going to be only talking about managing spine trauma everywhere from the cervical spine, the craniocervical junction, to sacrum and pelvis. So this will be a very big meeting, and I hope that you will all register to attend. But today I would like to welcome our speaker, Dr. Sudhir Ganesan, who is a senior consultant and an associate professor at Sri Ramachandra Medical College and Research Center. He's an excellent speaker, and he's going to bring us together some knowledge and some discussion about Asia A neurology. So the commonest query and the commonest discussion that we have is whether we need to stabilize this or decompress, or only do a stabilization alone. So I'm sure there's going to be a very interesting topic, because it's a common dilemma that a lot of us have when we have a patient with Asia A. So over to you, Sudhir.
Thank you, sir. Thank you for the introduction. And as Dr. Bala sir said, so we welcome you all to this ISSICON conference this year that is going to take place in Chennai. And once again, thanks Dr. Bala sir and the entire organizing team, Dr. Keerthi and Dr. Soma Sundar, for giving this opportunity to share my thoughts on this particular topic. So I'm just going to share the screen. Can you see my screen?
Yes, we can see your screen now. Yes.
Yes, sir. Yes, sir. Yeah. So let's start with the case example. So this is a 27 years old male who came to the ER with history of RTA and difficulty in moving both his lower limbs immediately after the injury. And there is absolutely no sensation below the waist level. And after the ABC protocol and everything, the images were done, and you can clearly see that there is a clear-cut fracture, dislocation, and spondyloptosis for about almost two spinal segments. And this is how he landed. And this is the MRI image of this patient, and you can see a gross fracture dislocation with spondyloptosis. It's a very, very high velocity injury. He just went and knocked directly against the barricade when he was driving a two-wheeler. And you can see the overriding of the entire vertebral column. And he was Asia A at his presentation. So today's topic is going to be Asia A neurology. It's going to be a very, very focused and specific topic because we are going to discuss only about Asia A neurology. Whether decompression alone, decompression and stabilization alone is needed, or stabilization alone is more than sufficient for these patients. So why are we asking this question? Why is this stabilization alone, or whether we have to decompress these patients? This question is because we all know that when there is complete spinal cord injury, we all know that spinal cord injury is an irreversible one. I'll just come to the pathophysiology or pathomechanics, which takes place immediately after the injury. So it is going to be an irreversible injury in case of complete spinal cord injury. So are you going to really do any good, or is it going to be really beneficial if you're going to decompress the cord, or you are going to cause iatrogenic injury, that is in the form of second hit phenomenon, by doing decompression of the cord? So that is the question. And is the patient going to really benefit from decompression? Because as I said, it's going to be an irreversible cord injury. And we all know that this is the Dennis three-column concept. I'm not going to go into the theoretical part in this particular topic. As I said, it is going to be focused. I'm just going to deal with literature, and I'll come with the take-home message with the general consensus. So we all know it's a three-column injury, and this ACIA neurology usually occurs with A4, that is a complete burst fracture, or it can be in B or C type of injuries. And this is the T-League score. This is just to brush through the main scoring systems and the classification which is available. As we all know, it has three components: morphology, integrity of PLC, and neurological status. And it is mainly to guide us whether the patient needs operative intervention or not. Patients more than 4 points usually needs surgery. And this is the standard AO classification that we use. So you start with, you have to see whether there is any displacement or dislocation. If it is there, it is termed as type C. And if it is a tension band injury, again, it can be B1, B2, or B3. B1 is pure transosseous disruption. B2 is osteoligamentous disruption. And B3 is hyperextension injuries, which is usually seen in case of ankylosing spondylitis or dish. It is an anterior tension band injury, B3, and it's a highly unstable injury. And if there is no tension band injury, and if there is a vertebral body fracture, then you look for the posterior wall involvement. So if the posterior wall is involved and both end plates are involved, then it becomes a complete burst. And if only one plate is end plate is involved, it becomes an incomplete burst. And if there is no posterior wall involvement, it could be either pincer or the classical wedge compression fracture. And if only processes fractures are there, like transverse process fracture or spinous process fracture, it is an insignificant injury. And this is the modifier, neurological modifier. So N4 is complete spinal cord injury. And as I said, as per Asia grading, Asia A is complete spinal cord injury. There is absolutely no sensation. There is absolutely no motor below the level of injury. And these are the M1 and M2 modifiers in neuro classification. Now, before jumping into whether decompression is needed or not, there is a lot of debate, and it's a very, very controversial topic regarding the timing of
Sudhir, we lost your voice. Soma, can you hear?
No, sir. Actually, I'll try calling Sudhir sir now. I'm calling to the surgeon.
Yeah, okay. Sorry about the technical glitch. I think,
Sir, he is reconnecting, sir.
sure, okay. I think probably he's driving, so he must have lost signal. So while we're waiting for him to get connected, it's very important to understand the classification systems for thoracolumbar fractures and cervical fractures, which are the very common fractures. And I think the classification systems helps you decide on many things, including.
Dr. Keerthi, can you hear me now?
Now, yes, we can hear you.
Yes, sir.
Oh, sorry, I don't know what happened.
No problem.
I'm
Please.
not able to share the screen. It says the other person is sharing.
I think, why don't you, Soma, it says that you are the, yeah,
Yeah,
now.
now I'm able to share the screen, sir. I hope my screen is visible now.
Not yet, sir.
Now?
No, sir.
Oh, wow. Share screen. Start broadcast. 1 second. Now?
Yeah.
Yes, sir.
No?
Not the president. Yeah, better. Yes, sir. Yeah.
Okay.
Perfect.
Okay. So sorry about the technical glitch. So again, the question is, yeah, definitely earlier the decompression, it is better for the functional recovery and neurological recovery. There are n number of studies which have said that earlier you do decompression, the patients improve in ACR grading by at least 1 grade. And again, there are n number of papers which has compared less than 8 hours, 8 to 24 hours, and 22 to 24 to 72 hours. And for all practical reasons, they say that 72-hour cutoff represents the most promising time window because these are all high velocity injuries. You have to stabilize the patient and you have to take the patient up. You have to organize your theater and everything. So you can have 72-hour cutoff, but however, less than 24 hours is ideal. But however, all these effects are very pronounced and the neuroprotective effect is very much seen in the setting of incomplete spinal cord injury, especially in the distal region of the cord. Most of the studies which has taken these patients and where decompression has been done, they have said that this is very, very prominent or significant in incomplete cord injury, that is from Asia B. But for Asia A, they say that it does not matter in a significant way. Though 1 or 2 patients had neurological recovery or less than 20% of the patients had neurological recovery, it is not statistically significant. Again, according to this particular paper, you can proceed with early surgical stabilization in a well-resuscitated patient unless extenuating medical conditions will prevent it. Now, let us take a scenario where you get a ACIA neurology and the patient's condition is not very much stable. Then you have to concentrate on stabilizing the patient first. Okay, you need not get into the theater and you need not do urgent decompression for these patients because, as I said, theoretically, it is not going to help you much. So when do you do urgent surgical stabilization? In case of incomplete or progressive neurological deficit, when the general condition is stable, and early surgical stabilization, that is, you post the patient in the next day morning in your, as a first case in your elective list. Instead of taking up the patient in the midnight, 2 o'clock or 3 o'clock, you can post them in the next day when there is normal neurology or complete neurological deficit. Now coming to the next question, decompress or not, and again, why am I telling that it doesn't matter in a significant way in Asia A patients? So you have to understand the pathophysiology. We all know that spinal cord injury is an irreversible mechanism because there are 2 components which takes place in case of spinal cord injury. First one is the primary injury to the spinal cord, which happens at the time of injury. That is the insult which is happening at the time of injury is called as the primary hit phenomenon or the primary injury where there is direct injury to the neurons. And at that point, the spine goes into a state of, we all know, spinal shock. Everything below the level of injury goes on to a state of shock. And in case of complete spinal cord injury, even the remoters or the innermost fibers of the neurons, they get injured. That is the sacral fibers, they get injured. That is why we call the term sacral sparing, because usually in incomplete cord injury, the sacral fibers will be usually spared because they are present in the innermost region of the spinal cord, and they are the last fibers to get affected in any velocity injury. So even if the sacral fibers are getting affected, it means that the velocity of injury is very high and the impact is very high. The next thing which happens is the secondary hit phenomenon. See, as surgeons or doctors, we do not have any control over the primary hit phenomenon, but the entire role of all the medication or decompression or surgical procedures, everything plays a vital role to prevent the second hit phenomenon. Even the steroids or the latest biologics or whatever is being discovered, it works only for the second hit phenomenon, where the red color cells, where you can see in the diagram, it is called as the reactive astrocytes. They come and they try to prevent the injury to spread in the spinal cord. So all this Valerian degeneration, regeneration, all those processes, they take place, and these cells, they form a barrier. Actually, it is like cough impulse. It is a protective mechanism. But unfortunately, this protective mechanism becomes a barrier for neural regeneration or neural differentiation. So that is the biggest challenge in the spinal cord microenvironment. And this is a fantastic area to do a lot of research and other things. But grossly, what you have to understand is surgical decompression is mainly to prevent the secondary hit phenomenon. Whenever there is a mechanical compression in the cord, it can hamper or it can be detrimental for neural recovery. Theoretically, all this is theory, because clinically or practically, it's very, very ambiguous, and the studies in literature is very confusing. There have been studies where they have actually measured the intraspinal pressure with and without decompression as well. But however, the results are not significant. They say even if there is a huge chunk of bone which is compressing the spinal cord, it is not going to be detrimental in the due course, that is after injury. If you say it is immediately after injury, the intraspinal pressure, or later after 2 weeks later also, there is no significant difference. So that is the confusing part here. However, again, as I said, literature is flooded with various concepts and opinions. I have just picked up the most important and salient points. So according to literature, early surgery was not associated with significant improvements in motor function in ASIA-A injury. Okay, early surgery means decompression. They mean decompression. Okay, and no significant rates difference in the rates of AIS grade conversion with early surgery as compared with late decompressive surgery in these patients. This again indirectly means that decompression is not going to matter significantly in ASIA-A patients. Now you can ask a question: why can't we just go ahead and decompress all these patients? Why are we just talking? It's just going to be an additional procedure, because most of these patients are going to require stabilization. Why don't we just go ahead and decompression? As I said, again, decompression may result in increased blood loss. It can result in iatrogenic injury to the cord. And by doing all posterior decompression, you may have to retract the cord or the conus to remove the retropulsed fragments or push in the retropulsed fragments. Now, coming to again this particular paper, they have showed that neurological recovery of more than grade 1 in ACIA did not appear to differ whether the patients were operated less than 24 hours or even after 72 hours. And around 40 patients with ACIA spinal cord injury, they showed at least grade 1 improvement. However, timing did not matter, but they showed improvement. Now, this is again going to be confusing, right? So you say that decompression is not actually going to help in ACIA patients, but however, in their research, they have shown that almost 40% of these patients improved by at least grade 1. But now the catch is this one. It could be because of abatement of spinal shock rather than an effect of early decompressive surgery. So they say that spinal shock, when you operate these patients less than 24 hours, the patients may be in spinal shock. And this improvement in grading could be because of the spinal shock period getting over. So it could be it could have been an incomplete spinal cord injury. rather than a complete spinal cord injury. So that is the confusing part here. And this is one of the very good papers where they have shown that the canal compromise had decreased significantly in the CT scan and MRI scan after 4 weeks of injury. And even the patients with incomplete paraplegia, they had improved by at least 1 grade, but irrespective of decompression. So the question of whether decompression simply or to remove the retropulse fragment is still a burning one. And this is by Dr. Alex Vakara and their team, published in Indian Spinal Journal. They said that canal decompression is an important goal in incomplete neurologic injuries. They have clearly mentioned that for complete neurological injury or complete deficit, again, the literature is very controversial, and it is a big question whether you have to decompress or not. And anterior approach permits, we all know that it permits better canal decompression, but there is very little evidence that it correlates with the neurological outcome. So again, what they are trying to tell is, irrespective of whether you do a complete decompression or an indirect decompression by ligamento-taxis or not, it is not going to actually correlate with the functional or neurological recovery. And hence it is difficult to justify one surgical approach over another purely with respect to neurological outcome. So neurological outcome, you cannot say that by decompressing thoroughly, this patient will get better. At the same time, you cannot say that I am not going to decompress, because even if there is 1% chance that the patient may become better with neurological decompression, we may have to take that chance. Finally, which kind of decompression is better, anterior or posterior decompression? So this is a meta-analysis which showed 4 RCTs and 3 controlled clinical trials, and according to them, anterior approach provides better restoration, sagittal restoration, and very good decompression, because you are going to directly decompress the fragments and see the dura or the cord. And however, there is no difference between both the groups and no difference in the clinical outcome, whether it is going to be anterior or posterior decompression. And compared with the anterior approach, the posterior approach demonstrated superior canal decompression according to this particular study. Again, so they claim that you can do all posterior approach in a very good way, and you can clear the canal. You can use the L punch or other kinds of punch to push in the retropulse fragments, or you can directly remove the fragments through an all posterior approach. And it had less operative times and less perioperative blood loss. However, because of lack of RCTs and large size studies, heterogeneity was significant in this systematic review. Even going back to the Alex Vaccaro et al. Study, anterior approach is usually advisable in patients with high load sharing cause, that is basically by the load sharing classification. Alternatively, short segment fixation with fracture level screws is equally supported. Now, coming to another case example, you can see a complete burst fracture in this patient with canal compromise. This patient came with Asia A neurology, and open surgical stabilization was done, and we did not actually decompress the spinal cord in this patient. However, at the end of 1 year, this patient had an improvement by grade 1. And coming back to the initial case example which we saw, you can see this fracture dislocation, and this was done long segment posterior instrumentation, and it was a very difficult reduction. Serial compression distraction maneuvers were done, and we had to reduce, and this is the long segment stabilization which was done. So in a nutshell, to conclude, whenever the patient has a neurological deficit, if it is a complete or when there is no neurological deficit, you can go ahead with early surgery. In case of incomplete neurological deficit, you should do urgent surgery. Incomplete deficit or progressive deficit, you have to do urgent surgery in these patients. So whether to decompress or not, neurological deficit, in case of complete neurological deficit, it is always better to decompress, though literature is very controversial, and equally good number of studies shows that it is not required, but medico-legally and theoretically, yes, you have to give the chance for the spinal cord to recover, even if it is grade 1, even if it is statistically significant or not. It is better to go ahead and decompress the spinal cord in these patients. Incomplete, there is no question. You have to go ahead and decompress. There is no question at all. And in normal neurology, literature suggests that you need not decompress. Even if there is canal compromise of about 67 to 72%, you can just leave alone because, as I said, when the primary hit has not worked, then there are it is a very unlikely that the cord may undergo injury in the due course of time after surgery. So you need not decompress because by decompressing, you may injure the cord because it's a compromised canal. So normal neurology, you need not decompress. And for our topic, for complete neurological deficit, it is better to decompress, though it is not the dictum. So the take-home message is incomplete deficit, you do urgent surgery. Decompression is mandatory in incomplete injury, and however, it is not mandatory, but it is better to decompress in case of complete neurology or initial. Thank you.
Thank you very much, Sudhir. I think the last few slides summarized it very nicely about this very question that everybody has. But you also ended up saying that though the literature is not supportive for various reasons, medical, legal reasons, clinical reasons, that we end up doing a decompression. So my question is, in your practice, leave alone this first example that you said, which is probably it doesn't matter whether you decompress or not. But in
Yes,
those
sir.
cases like where you showed, where you have an maybe a small bony compression, and you have an type B ACIA injury where you're stuck with this question. What is your practice in your practice?
So we usually do not open decompress, sir. We do not do open decompression or direct decompression. And definitely we do not do an anterior thorough decompression like anterior corpectomy or other things we do not do at all. What I personally do is indirect decompression by ligamentotaxis. That's what I do in complete ACIA, documented ACIA, because in our setting, many patients, they come less than less than 72 hours. Okay. So we do indirect decompression, and literature is quite supportive of that. And it says that indirect decompression can actually similar to that of direct decompression, especially in ACIA. So it's not actually going to matter.
Okay. Good. I think majority of people probably that's what they practice as well, is what literature says about the decompression. Now, before you do any decompression, what is the practice in your department about neuroprotection?
Oh, yeah.
What are the various steps that you all take?
For neuroprotection, sir.
Yeah, like
Again,
any steroids, whether you get them out of spinal shock, and how do you manage them?
so steroids, we do not follow the NACIS protocol, sir, and none of the tertiary care units, they follow NACIS protocol. But again, we give a loading dose of steroid to all these patients. So we give loading dose steroid, methylprednisolone, when the patient comes to the hospital. If it is less than 24 hours, definitely not beyond 24 hours. Less than 8 hours, not definitely beyond 8 hours. There is no role for steroids at all. But otherwise, there are many new molecules which is happening, which is not proven scientifically. And we are not doing any of that. We are not prescribing any of that. We try to maintain the MAP, mean arterial pressure, at a good level, and we take care of the ABC. Currently, we are doing research, and for which we got the Aerospine grant award, and that result showed the results were quite promising. We actually target the wind signaling pathway, and then we are on the verge of finding a molecule for the same, inhibiting the wind pathway. So that at a cellular level, it has worked, and now we are in the process of doing animal studies. So that is the current scenario.
Very good. So you mean that all patients who come through your emergency within 8 hours, you start them on a loading dose?
What, sir?
Sorry, no, all patients who come with ACIA,
Yeah.
within 8 hours, you start them on a dose. And what dose and duration do you give it?
Loading dose, sir, just 1 gram start Solimedrol or half an hour to 1 hour along with
All
plan.
age groups,
That is it.
all age groups.
All age groups. All age groups.
Right. So that again is very controversial.
Very, very controversial.
We have a debate and discussion in the conference with the current evidence.
Yes.
What it is.
Correct.
I think we will look into that. Soma, are there any questions in the group?
Mr. Rishi, are you?
So Keerthi, since you're a panelist there, I can probably throw the couple of similar questions to you. What is your opinion about decompression and stabilization, and what do you do in your practice?
But I actually worry about decompression in Asia neurology, where there is translation is what if if there is an irreparable dural tear? In that case, I have a question here, sir. If it is an irreparable dural tear, shall we put more time to repair it with the dural patch, or we can just leave it open? The dural
Yeah.
repair, if the dural repair has any impact on neurological recovery, sir?
Yeah. Yes, Dr. Kirti. So, in our experience, we have found that spinal cord injury associated with dural tears, you need not do anything. You just keep a patch and come out. Do not waste time. It has nothing to do with your neurological recovery, and you should not keep wasting your time. Usually, they heal very well, and they seal very well because of the intense amount of inflammation that is going to take place as a part of reparative process. So by trying to do dural repair, you are actually going to injure the dura more. And I think you need not do that. You can just get away with it. They heal well.
Okay, sir.
You will not get this draining CSF leaks or pseudomoningocele. It is very, very rarely seen in traumatic spinal cord injuries. Dr. Bala, sir, your opinion regarding this?
Yeah, no, I totally agree. See, usually these dural tears, sometimes their majority of them will also be anterior, and one you cannot repair. And second, the ones that are posterior, they are not a regular normal tear, so they are quite difficult to close. If it is something that you feel that you can quickly close with a few sutures within a few minutes, then yes, I would probably attempt. But if it's something that's going to take a lot of time, and as you said, patients under anesthesia, you want to really, get them, good perfusion, and you don't want to waste time. So, and I've also never seen any of these, but you should take good care in closing the fascia and the skin nicely, so that at least in the initial phase that there is no CSF leak and other complications. But I agree with you, you should not waste too much time in tearing. You can leave a patch, or you can leave a piece of fascia or something like that. Any other questions there? Soma, do you have any question?
Yes, sir. Yeah. So initially on presentations, just this is something which we everyone face usually. Initially on presentation, let's assume the fracture is not very severe, like a translation. However, let's assume there is a posterior complex involvement, and the patient is fine to take to OT, but we are in doubt because the patient, we don't know whether it is in a spinal shock or it is a true neuro Asia A. So in this scenario, what will be our thought process and plan about decompression or not? And in the scenario, I assume that the ligament access might be a little difficult with the posterior complex involvement.
Yeah, see, whenever there is a posterior complex involvement and it is a clear-cut injury, in those cases, you can just go ahead and decompress because that is not going to take much of your time. It is most of the times it will be a through and through, and associated lamina fracture will be there, and the entire ligamentous complex will be gone. So while exposure itself in these kind of high velocity injuries, it will be shaky and it will be loose fragment in the back. So you can just take it out and you can just remove the fragments. But I will not attempt doing any significant or heroic job of retracting the corners or the cord and pushing the posterior fragments inside, retropulse fragments inside, because by doing a proper stabilization and by getting the alignment, usually that goes and falls back, except when you suspect a reverse cortical sign, when the PLC is gone and there is a twisted fragment. That will usually not fall in place. In those cases, then you can definitely attempt doing something. Otherwise, with PLC injuries, usually you can just go ahead with decompression and give the best chance for the patient to recover. If you're suspecting that it is an incomplete cord injury, or since the patient is in spinal shock.
Thank
So,
you, sir.
just another thought. When this is what has been the basis of a lot of studies which have been done on decompression. It is you compare it because of things similar to the brain tissue, neural tissue. So when you have a head injury, your first thing is that yes, you cannot prevent the primary injury, but to prevent secondary injury, you and to increase the the hypoxia and the circulation, you do an craniotomy and you do a decompression. That is what led to the basis of many studies that came out, like situations like central cord syndrome and other places where people did an laminectomy, and even people went on to do durotomies. Any experience you have, since we're discussing about decompression, have you ever thought about doing anything along those extremes? At least in maybe not thoracolumbar injury, but in cord injury, thoracic injury, or cervical injuries?
No, sir. In complete neurology, no, I haven't done anything like that. Because again, as I said, so the reparative process is so fast. Okay, the reparative process is so fast. Even if there is going to be a retropulse fragment which is present in the canal, it's not going to cause secondary injury, secondary hit phenomenon. As I said, many studies in rats have shown that intraspinal pressures or the spinal cord perfusion pressure is not going to did not differ significantly after removing the retropulse fragment. And all those fragments or the compressive elements which is present in the canal, they get resolved very well, especially within 4 to 6 weeks. And by the end of 6 months, almost 80 to 90% of the fragment will be removed. Our aim is to just stabilize the spine so that it is not going to cause a continuous kind of compressive element or injury to the canal. The moment you stabilize, usually it falls in place and it is not going to injure the cord often, or it's not going to cause a secondary hit phenomenon.
Yeah. So this is again a very interesting topic, which we will be discussing in the conference when it comes to whether you have not much of a bony injury, but when you have a complete cord contusion, which probably happens more in and pre-existing myelopathy or a pre-existing OPLL.
OALF or
Whereas
OPLL, yeah.
where the phenomenon is very different compared to an acute trauma, where the phenomenon is slightly different. So, but that's a very interesting discussion, which we probably have. If there's no questions, then I think we'll close down. Soma, any more questions there?
No, sir, no questions yet from the audience. However, the forum and the YouTube link will be open, so viewers who are seeing it later may post in the questions, and we can check it once in a while and answer their queries.
Sure. Sudhir, thank you very much for taking time off.
Thank you, sir. Thanks for the opportunity.
Yeah, welcome. And we will discuss more about all of these things in the conference.
Sure, sir. Sure, sir.
Yeah. Thank you.
See
Thank
you
you.
also. Bye, bye, sir. Bye, sir.
Thank you. Thank you all. Thanks.
Thank you, viewers, for attending this meeting. And you can watch this at your leisure. And we look forward to seeing you at the ISSICON conference to discuss a lot of very interesting debates, discussions on steroid use, timing of surgery, level of fixation, how the classification is going to be helpful in your decision making, and also in your own outcome of your procedure, and what you need to do and understand about rehabilitation for bowel, bladder, and various other things. So look forward to seeing you all in the ISSICON conference. Thank you.
Thank you, sir. Yes.